Hey, Abrico Kelly here. We are doing something a little different from the normal Friday podcast. As many of you know, we have our annual Medicine in the Mediterranean conference each year in Malta on the last weekend in January. It is a great time of year to be there. January weather here in Europe can often be minus 10 Celsius, so heading down to Malta is a break from the Baltic temperatures. Malta in January is often warm enough for shorts and sandals. Over the next fortnight or so, we will be interviewing some of the speakers for MiM26. It will give you, the listener, a taster for the topics that we are covering this year. I will be offering my improvised medicine workshop again. We have workshops for the arc-light ophthalmoscope. Berger Langdana is doing his dentistry again. Eric Holmstrom has a workshop on CPD. And Dr. John Quinn has an all-day workshop on forward resuscitation and medical mobility, the case-based lessons in damage control resus and partial reboa. Dr. Quinn has just returned from another deployment to Ukraine with Quorum faculty, where they ran another DCR course. For this episode, I will talk with 3 of our students who will present their thesis topics. First, let's talk with Alfredo Leal, who just finished his master's thesis on triage in austere environments. So, Alfredo, welcome back to the podcast, and tell us what you're going to be talking about in the MiM26.
Hi, Eric. Good to be here. So, MiM26, I'm going to talk about triage, but in austere environments. Doing my master's dissertation, I noticed there's a lot of things that are not actually great when we're using our typical triage system, such as START, even the 10-second triage. There are a lot of things that are not right. And grabbing all that knowledge and passing towards the remote and austere environment, sometimes, imagine if we are in a remote location, we're going to start triaging a patient as red, right? When that the patient will be able to be evacuated from where we are right now to the near hospital, will be 5 hours away. So take into consideration the P1 triage, the red ones, will be patient supposed to be at the hospital in 60 minutes. Is the patient going to arrive there in 5-6 hours? Probably. All the resources we're going to use on that specific patient will be a waste. It's sad to say it, but it's going to be a waste.
So are you bringing any lessons learned from the Ukraine experience?
Not Ukraine experience. I've been there in 2020, but no, I'm bringing experience from other places, especially the logistic point of view. When I was in Afghanistan, I was as a medic, civilian medic, but I was in close contact with what was going on in terms of medical systems, in terms of evacuation and so forth, and also some learning that I had from other places that I've been offshore and Saudi Arabia. I spent 2 years doing HAMS and many other places. Also, all the literature that I came across, I checked about 60 something, almost 70,000 articles during and even before my master's.
Did you say you did a lit review of 70,000 articles?
Yes, probably more than that. I'll explain to you why. So I started studying triage in 2011 when I was doing a post-graduation in Portugal. The name was Medicine of Conflict and Catastrophe. Was not my first contact with triage, but it was my when I started realizing that things were not right. We're testing some triage system, and I remember doing an exercise. The doctor completely changed the triage category on the specific patient and asked, "Why are you doing this?" And she said, "No, I'm doing this because I'm a doctor. I can do it." And I then realized that actually she was doing the correct thing because the patient had the wrong classification while we were using an algorithm triage system. I think it was CEV, and then we use SORT. An example, if the patient is able to walk, it doesn't mean that the patient won't be red if we have an explosion, house fire. If the patient inhale overheated fumes, the patient will be able to walk, get out from the building, but probably in 20 minutes' time, he's going to develop a laryngoedema and going to have a airway obstructed, and then go into respiratory arrest and then cardiac arrest. And it was classified as P3 at the beginning. So those kind of details, that's I realized that they were not playing well in the great scheme of things. Triage was conceived mainly for trauma. Actually, going back to the Napoleon Wars, was mainly to triage the ones who were fit to go back to the battlefield, what they used to call reverse triage. And we kind of generalized and adapted the concept of triage to everything. And that when things start going less right, put it this way.
So for the
Yes.
listener who is currently working in an austere environment, what's the
Yes.
number one triage tool that you would advise people to use?
Well, that's a hard one. I already identify 167 triage systems, 60 of them for pre-hospital environment. There are two types. One is, at least according to my research, one is algorithmic, the one we mainly follow a protocol, very rigid protocol, and we come up with a decision. And the other one, it can make us think, it's got some opening to classify them. I to take into consideration my experience and all the articles that I read, the best one so far is SALT. The SALT triage so far. But again, it cannot, the SALT means sort, access, life-saving intervention, treatment, and or transport, because you need to use clinical judgment. However, depending on the level of expertise of each provider, if you have someone who is a brand new qualified paramedic or even a technician, they may not have the knowledge and experience to use clinical judgment to triage the patient accordingly. And also depends on the situation. So if it's a trauma is one situation, if you're dealing with a patient coming from a CVRN environment, the triage will not work. A heat or burns will be a totally different one. Tactical, the same. And again, austere environment, the same as well. And cold, heat, there's several factors that we need to think twice before giving a priority to a patient. But so far, according to my studies, SALT is the way to go. But I may be mistaken in next week, for instance.
Well,
Again, it depends. If you look at PHTLS and PEP manuals, especially the American version, because if you buy the British version, probably the triage system will be different. They nowadays use a 10-second triage, and the NHS needs. But if you look at both PHTLS and PEP and other courses, they present both the START triage and the SALT. And main reason is if for per environment, the paramedic or the healthcare professional or the provider is he's got the minimal knowledge to provide care. His knowledge and experience is not enough to develop clinical judgment. It's best to follow an algorithm such as START, SORT, and second triage, something like that. If you have a physician or a nurse or even a paramedic with broad knowledge, I think it's better to stimulate the clinical judgment and to decide is this patient going to survive based on this current situation, our resources and so forth, and thinking what the actual patient needs. Is it the theater? What kind of surgery is going to be? The patient needs blood. All those questions we need to do in 30 seconds or even less are a requirement to organize the scene. And so I think both work, but depending on the knowledge of the provider. But again, so far, as I said, SALT is the best up to date. But I've got more articles to review and more studies to do and more work to do in order to come up with a conclusion. That's what I'm aiming during my doctorate.
So when I wrote the field guide about 8 years ago, the first edition, we used the START. And it's what we found on the clinical practice guidelines with JTS and a lot of paramedic and pre-hospital systems. What is your review? What is your advice for using START versus SALT?
Okay, START already changed about 3 times. So the original START was actually using just a cap refill, and then they changed to modify START when they include presence of radial pulse. But there's a few studies that actually suggest that radial pulses are often present in severely hypotensive and hypovolemic patients. So it means that a present radial pulse is not always meant to be that the patient is a P2 or immediate or delayed, we can delay the patient. And then they change it to a combined start, will be combined to the jump start with start, so to include the pediatric patients. But then you start seeing that patients are different, and they, as I mentioned, the literature and the studies are coming from the military environment where the age is between 16 and 35, the combat age, if I say 16, in some countries. But if you go and apply those triage systems into the society between 0 and 99 to civilian society, with patients taking beta blockers, are going to affect the heart rate. Patients having all sorts of problems, even disabled patients unable to walk. Oh yeah, what if the patient's on a wheelchair? And what kind of triage system you're going to category you're going to give him? All those variables challenge the STAR triage to be accurate on a civilian world. At the moment, STAR is still a thing. It's 82, 88. So in the 80s, it was implemented. And SALT was in 2011. There are many more, as I said, about 60 triage systems, more than that are suitable to be applied in the pre-hospital care. But it all depends on the environment and the knowledge of the provider.
Well, I look forward to seeing your presentation at the conference, Alfredo, and of course, it'll be great to see yourself again.
Yeah, it was a pleasure. It will be a pleasure to see you all in Malta next January/February. We'll be covering January, February.
Sounds good. See you there.
Yeah, okay, see you there.